Hello, my name is Suresan. I'm a final year medical student, and I'll be going through some topics in urology today required for Met 3B. The topics we're going to cover are the following: lower urinary tract symptoms, urinary incontinence, benign prostatic hyperplasia, urological cancers, and scrotal swellings. Let's talk about lower urinary tract symptoms now. Patients can present with a variety of symptoms indicating a lower urinary problem. It is really important to take a thorough history because patients may not voluntarily give information as it may be an uncomfortable conversation for the patient. So, in order to cover all ground and to make sure that you as a clinician are not missing key information, it is important that you ask specific questions about each possible symptom. The table on the right-hand side outlines the range of symptoms a patient may present with. LUTS can be divided into three categories: voiding, storage, and post-micturition. The reason why this categorization is necessary is because it indicates the nature of the problem. And this is important as this determines the treatment plan for the patient. Let's look at the symptoms one by one under each category. So under the category of voiding, patient can present with hesitancy, which means they have difficulty to initiate urination. They may have poor or intermittent stream, so they have difficulty in maintaining a steady urine stream or to maintain a good flow. They may complain that they need to strain a lot to urinate, and also complain about incomplete emptying. These symptoms suggest that the patient may have an obstructive cause leading to their symptoms. Patients who present with urgency, frequency, nocturia, or urinary incontinence are said to have storage-related symptoms. And this is because it indicates that they have an overactive bladder. They may also present with post-micturition symptoms such as post-micturition dribbling, which means that there is involuntary passage of urine after completing urination, and they may also complain of incomplete emptying as well. And this is sort of similar to voiding, and it indicates an obstructive cause. So after taking a good history, what do you do next? Well, you would do a physical examination. You would do an abdomen examination to check for any pelvic tumours, to check for a palpable bladder, which may indicate that they have urinary retention. You can do an external genitalia examination. For example, in women, you would want to assess the tone of the pelvic floor muscle. You would also do a digital rectal examination, especially in males, because you would want to assess the prostate. You would also ask the patients to complete a voiding diary for at least 3 days because it helps us to identify any voiding patterns and also to identify the severity of their symptoms. You would do a urine analysis and culture to figure out, to identify an infection, a urinary infection, and the causative agent as well. If there are indications of renal impairment, you would do use and ease. In men, it is important to do a PSA test if they present with LUTS. So PSA test is a blood test that measures the amount of prostate-specific antigen in your blood. PSA is a protein produced by normal cells in the prostate and also by prostate cancer cells. It's normal to have a small amount of PSA in your blood, and the amount rises slightly as you get older because the prostate becomes larger. So, if there's a raised PSA level, an abnormally raised PSA level, this may suggest that the patient may have a problem with their prostate. It can indicate that they may have benign prostatic hyperplasia or even prostate cancer, which we'll talk about later on. It is essential that when you do order a PSA test, you only do it if you're sure that the patient did not have a prostate biopsy 6 weeks ago, a urinary infection 4 weeks ago, a digital rectal examination 1 week ago, and even vigorous exercise or ejaculation 48 hours before the test. The reason why that you have to ensure this is because all these things can provide a false positive result. The table on the right shows you the normal PSA cutoff values according to the age of the patient. And this is important to know so that you can identify when a PSA value is abnormally raised. In order to quantify the severity of the symptoms, the patients would do a questionnaire. The International Prostate Symptom Score is a scoring system that would help us to evaluate the baseline symptoms to allow assessment of symptom change once treatment is initiated. So a score of 0 to 7 would indicate that they have mild symptoms, a score of 8 to 19 indicates that they have moderate symptoms, and a score of 20 to 35 indicates that they have severe symptoms. In addition to all this, if you suspect that they have a voiding dysfunction or they may be retaining urine, you would want to do a bladder scan to measure post-void residual volume. This means you would ask the patient to empty their bladder, and then once they've done so, you'll perform a bladder scan to see if there's any urine retained in the bladder, and if so, how much volume is retained. If you think that there is a urinary obstruction, then you will do an ultrasound scan of the urinary tract. So, what are the causes of LUTS? In men, the most common cause of LUTS is benign prostatic hyperplasia. Then, secondary to this, you have UTI. However, in females, the most common one is UTI, and then you have menopause. Other causes of LUTS are malignancy, detrusor muscle weakness or instability, urethral strictures, which is a narrowing of the urethra, external compression, such as pelvic tumor, constipation, and even neurological disease. Another male-specific cause of LUTS is chronic prostatitis, which is the infection of the prostate. So now, let's talk about benign prostatic hyperplasia. Benign prostatic hyperplasia is a voiding disorder. It is the enlargement of the prostate gland due to the hyperplasia of epithelial and stromal compartments. It is non-cancerous. Normally, a prostate size is similar to a ping pong ball. And as I mentioned before, the prostate size increases as part of old age. However, in BPH, the prostate growth is much greater than expected. BPH often presents with voiding symptoms such as hesitancy, straining, poor stream, and incomplete emptying. Regarding investigations, you would do the things that I mentioned before, so physical examination, urine dipstick or culture to rule out infection. A PSA test is vital, and also a digital rectal examination to assess the prostate. Often on digital rectal examination, the prostate is enlarged and it would be smooth as well, not nodular. If it is nodular, it is often indicative of prostate cancer. Now, with regards to treatment, if the patient has no symptoms, then you would just reassure them. If they are symptomatic, you can advise lifestyle recommendations such as avoiding caffeine and restricting alcohol. If they have moderate to severe LUTS, which means that their IPSS score would be 8 or more, you would offer them an alpha blocker. If the patient presenting with LUTS has an enlarged prostate, then you would offer them 5-alpha reductase inhibitor first line. If they have a combination of both, so they have moderate to severe LUTS as well as a enlarged prostate, you would give them a combination therapy of alpha blocker and 5-alpha reductase inhibitor. So an example of an alpha blocker would be tamsulosin, and an example of 5-alpha reductase inhibitor would be finasteride. I have mentioned these drugs later on in the PowerPoint presentation. Sometimes BPH is not well managed with medication, and in these cases, or when a patient presents with complications of BPH, then you require surgery to sort the problem out. And the surgery that is used is called transurethral resection of prostate. It essentially cuts away the prostatic tissue. It is really important to know the complication of TURP. This is really easy to remember because it follows the mnemonic. The complications follow the mnemonic of TURP as well. So, T stands for TURP syndrome. TURP syndrome is a rare and life-threatening complication. So, normally after the TURP procedure, to remove all the blood and to clean this surgical area, you give irrigation solution. The irrigation solution contains high concentration of glycine and it is a hyponatremic solution. When large amounts of irrigation solution is used, it becomes systemically absorbed by the prostatic venous sinuses. And this results in systemic hyponatremia due to fluid overload, hyperammonia due to breakdown of glycine by the liver, and visual disturbance. So if someone who recently had a TURP procedure done, and a day ago, for example, and you are looking through their U's and E's and they have become hyponatremic, one of your differential diagnoses has to be TURP syndrome. And now, U stands for urethral stricture or UTI. R stands for retrograde ejaculation, and P stands for perforation of the prostate. It's pretty simple to remember this, and you should do because it often comes up in exams. So now, let's talk about storage disorder. An example of a storage disorder is urinary incontinence. Urinary incontinence is grouped into 3 categories: stress incontinence, urge incontinence, and overflow incontinence. Stress incontinence is when the patient presents with involuntary leakage of urine when they sneeze, cough, or exert themselves. And this is because their intra-abdominal pressure exceeds the urethral pressure, or because they have very weak pelvic floor muscle. In order to treat stress incontinence, they require 3 months of supervised pelvic floor muscle training. If this training fails, then they would be referred to secondary care to explore surgical options. If surgery is not ideal for them or they don't want to have surgery, then you can give duloxetine as second line. In patients with urge incontinence, they often say that they never make it to the toilet in time. And this is due to an overactive bladder, which can be caused by neurogenic causes, infection, or even malignancy. So for patients presenting with urge incontinence, you ask them, they need to do 6 weeks of bladder training. Bladder training is actually a form of behavior therapy. The goal is to increase the amount of time between emptying your bladder and the amount of fluids your bladder can hold. If after 6 weeks the symptoms persist, then you would add an antimuscarinic such as oxybutynin. If an antimuscarinic drug is contraindicated, for example, in elderly patients, you wouldn't want to give them antimuscarinics because of the potential side effects. You would give them a medication called mirabegron. I don't know how to pronounce this name, so please don't quote me on the pronunciation. If this also fails, then you can also refer them to surgery as well. Now, thirdly, overflow incontinence. This is often seen in patients who are in urinary retention. And they are often in urinary retention because of underactivity of the detrusor muscle or because of bladder outlet obstruction. So on examination, you may find a palpable bladder and they may complain of incomplete bladder emptying. So in these cases, you would have the management would be to refer them to secondary care. So regarding investigation of in the scenario of incontinence, you need to remember that incontinence is a clinical diagnosis. Therefore, no investigation is required. However, no investigation is required to confirm the diagnosis. However, if you want to, you may want the patient to complete a bladder diary to have a further insight into their symptoms, to do a urine dipstick test because they may have incontinence due to infection, and thirdly, you may want to do a bladder scan to measure the amount of residual urinary volume there is in the bladder. So this is a slide that summarizes a treatment plan for each type of LUTS. So firstly, storage symptoms. If someone presents predominantly with storage symptoms, then this signifies that they have an overactive bladder. You can manage them conservatively, which would mean that they reduce their fizzy drinks, lead a healthier lifestyle, and moderate their fluid intake. However, the first line treatment for storage symptoms is supervised bladder retraining for 6 weeks. If this fails, then you give them an antimuscarinic. And if that fails or if that's contraindicated, then you offer mirabegron. If a patient presents with nocturnal polyuria, then you would ask them to limit their fluid intake in the late afternoon/evening. If this doesn't sort out the problem, then you give them a loop diuretic in the late afternoon. And if this also fails, then you would have to refer them to urology, and you may want to switch diuretic to an oral desmopressin. For patients with voiding and post-micturition symptoms, this signifies that they have a bladder outlet obstruction, i.e. BPH. Similarly, you can conservatively manage them first, and you would only medically manage them if their IPSS score is 8 or more, i.e. moderate to severe symptoms, and in this case you would offer them an alpha blocker, such as tamsulosin. If the man has an enlarged prostate, then you would offer them a 5-alpha reductase inhibitor. If the man has both moderate to severe voiding symptoms and prostatic enlargement, then you give them a combination therapy of alpha blocker and a 5-alpha reductase inhibitor. I hope this slide clarifies things up. So, it is really important to understand the drugs that are given to treat LUTS. So, for an overactive bladder, so patients with storage symptoms, you give them antimuscarinics, such as oxybutynin. Antimuscarinic is synonymous to anticholinergics, so the adverse effects are blurred vision, constipation, dry mouth, and drowsiness. For voiding symptoms, such as for BPH, patients with BPH, you first give them an alpha-1 antagonist. This is because it decreases smooth muscle tone. However, the adverse effects of alpha-1 antagonists are dizziness, postural hypotension, dry mouth, depression, and sexual dysfunction. We give them 5-alpha reductase inhibitors, such as finasteride, in order to block the conversion of testosterone to dihydrotestosterone. And this is important because this conversion is known to induce BPH. So by blocking the conversion, we hope that the progression of the disease is slowed down, and also it helps to reduce prostate volume. Unfortunately, this takes time, and so symptoms may only improve after 6 months. The adverse effects of 5-alpha reductase inhibitors are erectile dysfunction, reduced libido, ejaculation problems, and gynecomastia. So that's it with LUTS. And now let's move on to urological cancers. So first up, prostate cancer. Prostate cancers are mostly adenocarcinomas. The symptoms are often due to bladder outlet obstruction, so they may have hesitancy or urinary retention. They can also present with hematuria or hematospermia. Prostate cancer is one of those cancers that can metastasize to the bone, so the patient may have lower back pain or even bone pain. They will also have weight loss/anorexia. In order to investigate patients with these symptoms, you would do a urine sample and culture to rule out infections. You would do a PSA test, which would be greatly raised in prostate cancer. You would do a digital rectal examination, which would show that the prostate is hard and nodular. And to visualize the cancer, you would do a transrectal ultrasound, and to get a biopsy, you'd use the same thing, and so you do a transrectal ultrasound guided needle biopsy, which you can do both at the same time. And then to check for metastases, you would do an abdominopelvic CT scan and a bone scan. To histologically grade the cancer, you use the Gleason scoring system. This scoring system categorizes prostate cancer into 3 risk categories. So a low risk category would have a score of 6 or less, an intermediate risk category would have a score of 7, and a high risk category would have a score of 8 to 10. So how do you manage prostate cancer? Those with the low risk category cancer, they would only require active surveillance. So this means repeated clinical assessments and repeated PSA testings. They do not require any invasive treatment. However, for those who have intermediate risk or high risk cancer, they require radical prostatectomy or radical radiotherapy with 6 months of androgen deprivation therapy. In patients with metastatic cancer, you would do bilateral orchidectomy or continuous LHRH agonist therapy. However, the downside of these two treatment is that they will not retain sexual function. So if for patients who hope to retain sexual function, you would do anti-androgen monotherapy. Now, moving on to bladder cancer. Bladder cancers are mostly transitional cell carcinomas. The risk factor for transitional cell carcinomas is mainly smoking and even past smoking, and also occupation that I have listed below. And that's really important to remember. And rarely you may have bladder cancer, which is a squamous cell carcinoma, and the major risk factor for squamous cell carcinoma in bladder cancer is schistosomiasis infection. Once again, I don't know how to pronounce this word, so please don't quote me on the pronunciation. The hallmark presenting symptom of bladder cancer is painless hematuria. If anyone who is sort of over the ages of 50 who complains of painless hematuria, you would 2-week wait refer them for suspected bladder cancer. They may also have dysuria as well. So as part of investigations, you would also do urinalysis to check for blood, renal function. However, the diagnostic investigation or the gold standard investigation for bladder cancer is a flexible cystoscopy and biopsy. The clinician may also want to do a CT urogram as well to identify the cancer. So the management is very much dependent upon whether it is a muscle invasive tumour or if it's a non-muscle invasive tumour. So in those who have non-muscle invasive tumours, the management would be to do a transurethral resection of a bladder tumour, or TURBT, along with intravesical chemotherapy. In patients with muscle invasive tumours, radical or partial cystectomy with urinary diversion is done, with pelvic node resection with chemotherapy. Now, testicular cancers. So, it is important to have a basic understanding on the different type of testicular cancers. So that's why I've created this little diagram which hopefully helps to illustrate the different types. So, 95% of the time, testicular cancers are germ cell tumours. Germ cell tumours are then divided into seminoma and non-seminomas. Non-seminomas are then further divided into teratomas, yolk sac tumours, choriocarcinomas, and embryonal carcinoma. The remaining 5% of the time, testicular cancers are non-germ cell tumours, and they are Leydig cell tumours and Sertoli cell tumours. And you would have come across this in second year histology, I believe. So, testicular cancer would present as a unilateral painless lump. It is firm, it is irregular, and it is a fixed mass. There might also be evidence of metastases. So in this case, there would be weight loss, back pain, because of retroperitoneal metastases, and dyspnea due to lung metastases. Testicular cancer is one of those few cancers which metastasizes to the lung. Regarding investigation, you would do an ultrasound scan of the scrotum. That is first line. You need to remember that in testicular cancer, you do not, and I repeat, you do not do a biopsy. And this is because by doing a biopsy, you can cause seeding of cancer, and so it can promote the spread of cancer. So testicular cancer and also liver cancers, I believe, do not require a biopsy. So in order to stage the cancer, you do a CT scan of the chest, abdomen, and pelvis. In testicular cancers, you would also look for blood tumour marker levels, because each type of testicular cancer may release specific chemicals. For example, beta-HCG is elevated in all cases of choriocarcinoma. AFP is elevated in non-seminomas, so that includes embryonal carcinoma, teratoma, and yolk sac tumor. LDH is an interesting one because it does not determine the type of cancer, but it determines the volume. So if LDH is increased, that means the volume or cancer bulk is greater, is increased. So it sort of indicates the bulkiness of the cancer, how bad it is, I guess. Regarding management, the definitive management for testicular cancer is radical inguinal orchidectomy. I'm now only going to concentrate on two types because they're the most common ones, seminoma and teratoma. Seminomas are seen mostly in patients between the ages of 30 to 45 years. They produce placental alkaline phosphatase, and the route of spread is via lymph nodes to para-aortic nodes. Here, besides radical inguinal orchidectomy, the patient also needs radiotherapy. However, in teratoma, this is more common in younger patients, so 20 to 35 years of age. Teratoma produces AFP, and the management for this is chemotherapy and radical inguinal orchidectomy. And that's all the cancer related to urology done in one slide. And now I'm going to talk to you about scrotal swellings, and this is the final part of the presentation. So, what are the differential diagnoses of scrotal swellings? Well, firstly, in no specific order, it may be a hydrocele. So what is a hydrocele? Hydrocele is an accumulation of fluids around a testicle, either due to an increased fluid production in tunica vaginalis or due to a patent tunica vaginalis. It may develop due to an underlying cause, so due to testicular torsion, testicular cancer, Epididymo-orchitis, trauma, or after a varicocele operation. We'll go through majority of this in the following slides. It presents as a painless fluctuant swelling. It will transluminate when a pen torch is shone. It is not separate to the testes, so you cannot separate it from the testes. It will feel as one bulky thing. And then the mass may increase in size with certain activities such as coughing, straining, crying, or even raising the arm. And it may appear smaller in the morning and smaller after lying down as well. Once again, all scrotal swellings are a clinical diagnosis, so no investigation is required. However, if a patient between the ages of 20 to 40 years present with a hydrocele, you would have to do an urgent testicular ultrasound to exclude testicular cancer. So please remember that. Regarding management, if in an infantile, you would normally reassure the parent that the hydrocele is likely to resolve without any treatment by 2 years of age. If, however, a hydrocele persists after the age of 2, then surgery may be required, so they will have to be referred to urology. In men or adolescents, idiopathic hydrocele, if they have an idiopathic hydrocele that just sort of popped up, you just reassure them and you leave it. However, if it is large and uncomfortable, then you would refer them to urology for surgery. And for those, I believe, who do not want to do surgery, you can do sclerotherapy as well. Instead, I mean. Secondly, another differential diagnosis of scrotal swellings is epididymal cysts. This is the most common cause seen in GP. It is benign. They are fluid-filled sacs arising from the epididymis and is often associated with polycystic kidney disease, cystic fibrosis, and von Hippel-Lindau syndrome. Similarly to an hydrocele, it transilluminates as well, and it's a small, smooth, fluctuant nodule. However, in contrast to hydrocele, since it is associated with the epididymis, it is found above the testes, and also it is separate from the testes, and also found posteriorly sometimes, most of the times apparently, according to PassMed. And often these cysts are multiple in nature. And regarding symptom, it's just supportive treatment. I don't think you do anything with them. Another differential for scrotal swelling is testicular tumours, and I've gone through that in the slides above, so please do look at them. Fourthly, we have varicocele. Varicocele is a collection of dilated veins of the pampiniform plexus in the spermatic cord. Patients often say that it feels like a bag of worms, and they complain of a dragging sensation, and it often disappears when lying flat. Valsalva maneuvers make them prominent. 90% of the time, varicoceles are left-sided, and this is because the left spermatic vein drains into the left renal vein. However, the right spermatic vein drains into the inferior vena cava. Red flag symptoms are when it is acute in onset, it is right-sided, and it remains when lying flat. This requires urgent investigation. So, varicocele is a clinical diagnosis. However, if there is diagnostic uncertainty, then you can do an ultrasound scan with colour flow Doppler. Varicoceles are graded according to their size. Subclinical means that they are only detected by a Doppler ultrasound. A grade 1 varicocele means that it is only palpable after performing a Valsalva maneuver. A grade 2 one means that the varicocele is palpable without performing a Valsalva maneuver. And grade 3 means that it is visible through the scrotal skin. It is important to remember that varicocele is associated with infertility. So it is important that sometimes you'd have to check for testosterone levels. You check the FSH levels, because an elevated FSH means that there is testicular dysfunction. And also you may have to perform semen analysis. So, Management of varicocele. In adolescents, if they have a subclinical or grade 1 varicocele, you just reassure them. Everything is fine. If they have a grade 2 or 3 varicocele and symmetrical testes, then you would observe them with annual examination. However, if they have grade 2 or 3 varicocele and asymmetrical testes, then you would have to refer them to a urologist for possible surgery. In men, if they have subclinical or grade 1, then you just reassure. However, if there is a concern regarding fertility, then you may have to do semen analysis. Grade 2 or grade 3 asymptomatic varicocele with normal semen parameters means that you observe the patient every 1 to 2 years and perform semen analysis. In patients who have grade 2 or 3 symptomatic varicocele or with abnormal semen parameters, you would have to refer them to urologist to talk about surgical options. Number 5. Epididymo-orchitis. This is inflammation of the epididymis and or the testicle due to either STI or an urine infection. So, the causative agents differs according to the age of the patients. In patients who are younger than 35 years, STI is the predominant cause. So chlamydia is the most common cause. Then comes gonorrhea. And in patients who have anal sex, E. coli is the culprit. In patients with greater than 35 years of age, it is often E. coli, the causative agent. They present with dysuria and urethral discharge. They would also present with unilateral scrotal pain and associated swelling. It will be tender on palpation, and they may also even present with LUTS as well, and have fever. It is a clinical diagnosis once again, but to identify the causative agent, you may want to do a urine culture / dip. You would want to do a first void sample and NAT or urethral swab to identify the causative agent in a suspected STI infection. So when I say first void sample, that means it's an early morning sample. You wake up and you ask them to give a sample of the urine that they do first thing in the morning, and you would give it to the lab to use NAT to identify the causative, identify the bacteria, identify the bacteria. And then you would do a urethral swab if there's any discharge to identify the organism as well. Okay, so this is an important thing. With Epididymo-orchitis, the cremateric reflex, I think I'm saying it right, is intact. Okay, the reflex is intact. However, they have a positive Prenz sign. Once again, don't quote me on the pronunciation. So a positive sign means that when the patient is supine and scrotum is elevated, the pain is relieved by the elevation. This is highly suggestive of epididymitis. Please remember that. So the management of Epididymo-orchitis is dependent according to the organism. So if it's an enteric organism, which means E. coli, for example, then you'd give them ofloxacin or levofloxacin. If it's an STI organism, i.e. chlamydia or gonorrhea, then you give them ceftriaxone IM and doxycycline orally for 10 to 14 days. So ceftriaxone is given IM as a single dose, but along with it, you would also give them oral doxycycline for twice a day for 10 to 14 days. And during this time, patients should abstain from sexual activity until the antibiotic course is completed and symptoms have resolved. Oh, I'm so sorry, my battery is super low and the message has popped up. Hopefully this sorts the problem out. And finally, you have testicular torsion. Testicular torsion is when the spermatic cord and its contents twists within the tunica vaginalis, leading to ischemia. A major risk factor of testicular torsion is undescended testes. It presents with sudden onset acute unilateral testicular pain. It is painful. And the cremasteric reflex is absent, which is the opposite of Epididymo-orchitis. Is that right? Yeah, Epididymo-orchitis. And similarly, the French sign is negative. So when you do elevate the scrotum, the pain continues. And it is associated with nausea and vomiting, and they may be referred abdominal pain as well. This is a clinical diagnosis. If you suspect someone to have testicular torsion, you rush them to surgery. You do not do any investigation. You don't waste time doing an ultrasound scan. You don't waste time doing, anything else. You literally prepare them for surgery, because testicular torsion is a surgical emergency. So in surgery, they will perform a scrotal exploration to assess both the testes and the spermatic cord. The management would be bilateral, not unilateral, but bilateral orchidopexy. And it's important, the reason why it's an emergency is because there's a window of 4 to 6 hours from the onset of symptoms in order to salvage the testes before major ischemic damage occurs. If, unfortunately, testes are non-viable, then orchidodectomy may be warranted and a prosthesis will be fitted. Thank you so much, guys, for being patient with me listening to this lecture. I really wish you all the very best of luck. If you can able to contact me to provide feedback on this, that's greatly appreciated. You could also pass on the message to Pal. I very much look forward to hearing your comments. But yes, hopefully you enjoyed it, and thank you once again, and wish you all the very best.